fusion 2 years ago.
Okay.
In C67.
What was the reason for the fusion?
Burst disc. So herniated.
Okay.
Herniated disc.
With arm?
Yeah, arm.
Oh, his
right.
whole body was...
Okay.
I was spasming.
Okay.
So a lot of bad.
And after this surgery, after the fusion?
Spasm stopped.
Okay.
My neck remained crunchy.
Okay.
So it's like bone on bone.
Okay.
No
And
hurt.
how do you feel it now? Is it more or less that you have muscle tension problems in your neck, or you have a problem with the mobility of the neck, or?
Numbness and tingling in both hands.
Yeah.
And my neck is still crunchy. It's almost like it locks.
Okay. And so from the surgery itself, there was no problem, no complication. You after the surgery, you can stand up and move your head.
It was very successful.
Okay,
Yeah.
good. And it was 2 years ago.
Yeah.
Yeah, and then he had numbness in the other hand.
Yeah.
Did they ever mention other kinds of surgical interventions like artificial disc replacement in Australia, or they just offer the fusion?
Fusion only.
They refused it when he asked.
Okay. Where did you hear from the artificial disc replacement?
On the internet.
Okay.
Through people that also have had back problems.
Okay.
That do not have the, how do we say, the fortitude to do it themselves.
Okay.
Pass off the information, and I'm the guinea pig.
Okay. And for you, if you hear that there is another possibility, instead of the fusion, the artificial disc replacement, you think, well, that sounds good.
That's a lot better than having a fusion.
Good.
With the problem that I have with multiple in my neck,
Yeah.
it would mean I'd have to give up work.
Yeah.
I wouldn't be able to jump on the trampoline with my children. My neck would be in one place.
Okay. And the neck problem is not the only issue,
No, lower back is also an issue.
but not too worse, or is the same? You said it's more or less.
Yeah, it's same,
Same
different but
problem.
the same.
Yeah.
So the upper is arms,
Okay.
numbness, tingling. The lower is legs,
Okay.
both legs. Numbness, tingling, weakness, walking on jelly,
Okay.
collapsing, and just pain.
When he lays down, he'll fall. The other day he laid down, he fell, and I couldn't hear him screaming from outside. He couldn't get up, he couldn't move. I had to pick him up.
Do you take regular medication, pain medication?
Yeah, Palexia,
Okay.
sustained and immediate release.
Okay.
Also gabapentin
Okay.
and
So
Cervical.
Okay. The plan for tomorrow is to do an artificial disc replacement, in your case, cervical spine and lumbar spine.
Yeah.
So lumbar spine, we have only a big problem with the level L5 is 1, what is the lowest level of the lumbar spine. I will show you the X-ray and explain you how it works.
Yeah.
But first of all, you read these informations.
Yes.
So about the surgery, and they explain in the information how the surgery will work.
Yes.
And of course what can happen during the surgery. So let us first go through the papers, so then I can answer your questions, or my questions,
Yeah.
if you see the X-ray. Okay?
Good.
So, this is information about the prosthetic intervertebral disc replacement in the lumbar spine. It's in English for you so clear to understand. If we talk about the surgery, first of all the question is how we can do the surgery. Well, we have to do an incision under the belly button. And if you see these pictures here, you can see the spine. So the lowest level is here in your case in the level L5 is 1.
Yeah.
There is one we have to talk about. These are the vessels in front of the spine. What means normally every human being is built like that. There are vessels in front of the spine. We have to prepare it so that we have enough space to go into the disc space, remove the disc, and then to bring in the implant. Okay. So if you see its pictures here, the incision will be like this, an horizontal incision, length like this.
Yep.
The reason for the length is because I have to go with my hands inside and do the preparation to the spine. And then we have some kinds of retractors to hold all the stuff in position, and then we do the preparation work for the vessels. In your case, there is a bifurcation. We just have to do a little preparation of the vessels and push the vessels to side.
Yeah.
So that we have enough space to go into the disc and remove the disc. After that, we put in the implant. One of the most questioned is what kind of implant we use. You know, when you heard it, we have two different implants.
Yes.
The M6 and spinal kinetics and the ESP. They're built a little bit different. So one is a bolt socket system, the other thing is a viscoelastic model. They are both very, very good, and we have from both implants good experience. But sometimes it is not possible to bring in the M6, and sometimes it's not possible to bring in the ESP. And I will explain why. Because we are not built same.
No.
So you will maybe have a smaller vertebral body than me, and especially a woman will have a smaller vertebral body than you. And also the angulation is different. What means the lumbar spine is not straight, so we have a lordotic angulation. What we have to find the best implant for it.
Yeah.
What means if we bring in the disc, we don't want that the implant will migrate or move. You have some problem with that. So we have to talk about primary stability. What means if we bring in the implant should stay in place. But that I will discuss on the models. Okay? Good. Then we have to discuss the possible complications. Really, the complications are rare, but if you read that, you get afraid because there are a lot of complications what can happen. And to be honest, all these kind of complications can happen during the surgery. But we decide in between complications what happens during the surgery, what we see. For example, if there is a bleeding, then we fix it.
Yeah.
And there are some complications we cannot see during the surgery.
Right.
For example, infection.
Yeah.
So because the infection developed in the days after, or weeks or months after the surgery. Well, all these kind of complications what can happen are treatable, and you don't have to be very afraid for them. So if they are happen, then we can fix them and we can handle it. Okay, but we can go over this kind of complications. So then let us start with the picture. And we start with the lumbar spine. This is the X-ray of your lumbar spine. So we talk about the lordotic angulation you can see here. So the lumbar spine is not straight. There is a curve, okay? And when we talk about your disease, we talk about the level L5 as 1. You see a distance in height here? And it's different from here to here. What means the disc diminished in height, but it's really normal in age, okay? So a degeneration. But in your case, we also see in the MRI a herniation and an impingement of the nerves will give you these sensations in your legs and the problem, okay? So the plan for tomorrow is to make the incision here, go directly to in front of the spine, do the preparation of the vessels. We cannot see on the X-ray right now.
Of course.
Then we remove the disc and then we bring in the implant. Good. So the plan for tomorrow is we start with the lumbar spine, due to the fact that you have to lay on your back. After that, we turn the table, and then we do directly after the lumbar intervention, the cervical intervention. Your question, of course, surgical time. What do we need for the time? We are not in a hurry. What means I cannot tell you exactly how long the surgery will need. The time surgery we need. What means the expectation for the lumbar intervention will about 15 minutes to 1.5 hours. Then we have to turn you around. Just the cervical inspection and bringing in the implant 1.5 to 2 hours. But overall, the whole surgery time is about 4.5 to 5 hours due to the fact that the anesthesiologist has to work with you, you do the intubation. After that, or after the surgery, of course, we have to close the skin and then you go in a wake-up room. And we will not wake you up. So if you are tired, not due to jet lag, but if you're tired due to the medication, we will not shock you and wake up because you have to leave the wake-up room. So if you need your time in the wake-up room, you need your time. The plan is that we bring you back to the private room at about 2 or 3 o'clock in the afternoon. So you're waiting for him. Potentially we're not going shopping or something like that.
He says I should. I said no.
No, you can do that. You have a lot of time then. But in the afternoon I come to you and for visitation. You may be a little bit tired, but we can talk about how was the surgery, what we find out, what we see, what are complications we have to fix during the surgery or not.
And what sort of time in the morning will you start?
Oh, early in the morning, what means wake up for you at 7 o'clock, you go down to the operation theater at 7:30 and we will start the surgery at 8:30.
Okay.
Thinking what you have to think about the function of the disc is the mobility.
Yeah.
What means we have these kind of mobility in the cervical spine. You know, the cervical spine is really necessary that all the segments can move. Because you want to turn your head like this, like this, like this. And if this is not possible, it's fused, you cannot move your head. So you always have to turn with the whole body. That's not really good. Otherwise, you have a lot of muscle tension problem, but give you neck pain, headache. And if you have an impingement of the nerves, also you have the arm pain and sensation, numbness and tingling in your arms. Okay. So if we talk about this model here, what is the original model, and this model, how it works is we bring it in the place in between the vertebral bodies with possibility of shock absorption and mobility. If we talk about the primary stabilization, if we bring it into the space, there is a lot of pressure on it.
Yes.
From your weight, from the muscles, from the ligaments. And you see on the surface of the implant there's a few pins on both sides, and they are pressed into the vertebral body. And these give you the stability that is not looking out.
Yeah.
Okay, or not move out. Okay. The pins are just for the first month. Yeah? Because the surface has the possibility that the bone can grow into the surface.
Graft.
Yeah. What means about 6-9 months, then the bone is completely grow into the surface of the implant, and then you cannot move it out. Okay. Even after the surgery, 2 or 3 weeks after, it is really hard to remove the disc, because we see there's not only the compression, not only the pins that hold it in position, but also there starts the bone growing directly after the surgery. Okay. If we see the other model, the M6, unfortunately we don't have the model here right now. There is, but you see it maybe on the internet.
Yes.
There are keels.
Yeah.
And these keels are with a sizzle preparation into the surface of the vertebral bodies, and they are fixed with keels. The system is nearly the same. The reason why we have the spins or the spins is that we have a primary stabilization. If we see this implant and the M6, they work a little bit different. Not too much, but in the M6 there is a ball inside in the middle, and they work like a ball and socket model. Also with possibility of shock absorption. But we have to do the measurement of the right implant, because we have to see how is the footprint, how is the angulation, and how is the height for the best restoring of height, angulation and mobility for you. And so now I cannot tell you what is for you the best implant.
Okay.
If you see the X-ray, you can say, well, normally we would expect that the ESP will work, especially in your cervical spine. But during the surgery we have to do the measurements, so it could be that we have to change.
Yeah.
We will not change during one spine, what means we're not doing ESP and M6 and ESP. Yeah? So if the ESP is working, then we put the ESP in. If the M6 is working, then we put the M6 in. We also want to avoid to give you different models in the cervical and the lumbar spine. Okay. But so this is the first what we want to do. So we start with the lumbar spine. What means you have to lay back on your belly button, on your back, and you have to do a lot of preparation work. You have to bring something that all the guts is clean.
Yes.
And then we start with the surgery.
Talking about recovery and surgery options afterwards that were successful, were unsuccessful, we might have problems, we might not. When you're talking with someone that's been through surgery but still under medication, it does not make sense. To have someone with, as a support person.
We have a history of non-communication to me, and they tell him everything and he can't remember anything.
Yeah, that's the reason, because
And it's very
normally
frustrating.
I do not talk with him. I say hello and put your hands on your legs, because you can forget it immediately after
Yes.
the meeting.
Yeah.
But communication is really, really important,
Yes.
especially for the patient, but to be honest, more or less for the companion.
It's been a long time with all of his issues. that
Because
no one
he
talks.
has his medication and he lays down and he's tired, and you have a lot of questions. He's not waking up, something's going wrong, so I just can't tell you enough. Talk to us. If you have a question, you have a direct contact person named Jessie. You will meet her in the afternoon. He's responsible for the direct communication. If you have a question, you can get in contact completely directly to her, and she will give us information if we need to get in contact to you because you have a special question or we answer. Or Jesse is American, so native speaker, much better than we can do that.
You're doing well.
And so that will not be a problem. Okay? So you're not alone. And on the other thing, you're also not the only patient on our station. So there was a lot of people from Canada.
Yes,
So,
we met them.
yeah. Now it's time for your questions.
There is everything has been clarified. I've had a lot of information given to me. I've had a lot of support from Spine Connection, from Jade. He's done a wonderful job of explaining everything. I've had a lot of information from ONZ, which has explained a lot in paperwork, which has given me time to read and understand than just listen to someone talk.
Okay, that will not stop after the surgery. So if you have problems or questions after the surgery, of course, you also can contact us or Jake, who did a great job in Australia, and it's in your time zone, so it's easier to get access to him than us. But via email, it's all just one click away.
Yeah, that's right. My wife might also have questions, but I don't have questions.
Okay,
I'm
now it's your turn. What's your questions?
I can't think of any right now.
You're nervous?
Yeah.
But don't worry. Okay. What that is not. Me too. No, I'm just kidding.
Yeah.
I'm not nervous. So. We will start with you.
I do have one question. When he had the fusion, his nerve was incredibly damaged.
Yeah.
They said it was, the words they used were trashed, scratched, ripped and bleeding. It was the words that the surgeon told me on the telephone. What is the chance that there is still some damaged nerve there and this might aggravate the nerve in the neck?
Okay, so what we can do is we can remove the impingement of the nerve so that the nerve has more space.
Yes.
But it's a good question because if there was too much pressure on the nerve, it could be that there are scar tissue inside the nerve.
And that is a residual pain.
Right,
Yes.
residual pain or residual neurological deficit, what
Yes.
means numbness or tingling.
And you won't really know that till you go in, I suppose.
Yeah, we don't know yet, but on the other side, you don't have these problems permanently now,
No.
right?
His
So,
elbow pain.
Yeah, what is good? So if we talk about a patient who have numbness or tingling in his arm for years or months, then we know our expectation is low that we can fix that.
Yes.
Okay. In your case, we know that the problems what happens sometimes are due to the fact that you have the impingement of the nerve.
Dr. Illerhaus, what's the plan for today?
Well, the plan is an artificial disc replacement in level L5S1 in the lumbar spine and also 3 level intervention in the cervical spine with artificial disc replacement. The reason is Mr. Wimmer is suffering a lot from back pain and also neck pain, and we see in the MRI that there is a severe degenerative disc in the level L5S1, and also he had a fusion in the level 6-7 cervical spine already. And he always, he told us yesterday that he suffered from neck pain as well. And we saw in the MRI of the cervical spine that there also degeneration of the disc in the level above, 3, 4, 5, and 6. And we also see a herniation and a narrowing of the spinal canal. And so that's the reason why we have the indication for a 3-level intervention in the cervical spine.
The timeout is one of the most important steps before we can start with the surgical intervention. The timeout is law in Germany. We have to do it before we start with the incision. During the timeout, we identify the patient again. We talk about the procedure, what we expect, how we react if we have a complication, and what is the plan for the patient after the surgery. For example, pain medication, intensive care unit, or can he go back to the normal station?
Noch one?
So this is all what we need for the preparation. The skin incision is about 5 centimeters, that's all. And after the preparation, you see there's no much bleeding. You can see directly to the spine and to the discal fibers 1. And now we start with the preparation. And during the preparation, this is all what we have to do for bleeding. Yeah. Nächster Schritt.
Okay, what are we doing now?
Well, now after the preparation, we try to loose the disc with a special dissector. So we go in between the disc, surface of the disc, and the surface of the vertebral body. Do that very, very gently, because behind the disc, you know, there's a spinal canal with all the nerves. So they're very small and gentle movements.
Dr. Illerhaus, we get asked all the time if it's possible to take the disc out in one piece. So,
Well,
is it?
No, normally not, because due to the fact that there is a degeneration at the disc is destroyed, and also it's like glue inside the vertebral body. So we are happy if we have big pieces of the disc, but due to the time we have to remove the disc, we normally have to destroy it.
And what exactly is this?
Well, this is pieces of the disc. So we have 4 sets where we can remove the disc, and these are all the parts we remove from the disc.
Vielleicht ein weißer was drunter, eine frische kommt, geht das?
Gucken, ob du das. Okay. So what we can see here is a part of the disc. It's in the middle of the disc, and we see how big is the degeneration here. You see these yellow spots?
Yep.
Normally the disc is white, and here in the middle we see that the core of the disc, or the nucleus, is completely destroyed, and it breaks into pieces here. Okay, now we finally remove the complete disc. You have now a good overview into the spinal canal. There is also a retractor inside the disc space to open it. And this is all we have removed from the disc here. This is the whole material you see. It's destroyed into pieces. You can see some pieces with spots on it. What means there is from the plate of the disc, and also the material of the whole disc what we have removed.
Okay, so what are we doing now?
Well, now we do the measurement for the implant, what height, footprint and angulation. And we start with the ESP implant. We put it into the disc level. And as you can see here, the footprint of the ESP is very good. But it's a little bit loosening due to the fact that your angulation is very, very high. So in that case, we have to try the M6. Okay, now we decided to use the M6 due to the fact that the measurement with the ESP was a little bit too loosened. And now, if you see here on the X-ray, if you do the mobility test, it's not moving around. So in his case, in the lumbar spine, the M6 with 16 degree is the best implant. Okay, now we can see this is the trial implant and also the sizzle for the primary stabilization. So it looks good from the angulation. This is the 10 millimeter height, 16 degrees angulation, and the size is L.
Ready. Now we can see how the implant is being inserted under X-ray control. X-rays are taken out throughout this procedure to make sure that the implant is where it's supposed to be.
Okay, here you can see the final implantation of the implant. It's in between the vertebral discs. And you see the incision is not really big. If you see my hands, it's about 2.5 to 3 fingers wide, the incision. Okay, now we want to start with the second part of the surgery, the cervical spine. And I want to show you the X-ray. If you see here, the positioning of the patient, we are already ready to go with the surgery. And you can see here that we restore with the positioning of the patient lordotic angulation of the cervical spine. And you can see here the fusion in between 6 and 7. But you can also see that there is a lot of bone spurs that going into the spinal canal in the level 3, 4, 5, and 6. And that's the reason why we have to do the surgery, because these bone spurs do an impingement of the nerve and that causes the pain.
We always use the microscope if it is possible. The microscope gives us a good overview for the discectomy and for the decompression of the nerve roots.
Okay. Now after the decompression of the first segment, the segment 5, 6, you can see the difference. Here we can see the bone spur that going into the spinal canal, and here after the decompression there are no bone spurs. And now we are ready for the implantation of the artificial disc.
You can see here how we implant the device under X-ray control in the level 4-5. After that we go on with the next level. First of all, we have to remove the screw and bring it into the level C3, always under X-ray control, and then we start with the discectomy and with the decompression under microscopical view. We don't need to do another measurement, height, length and size of the implant, due to the fact that we can see that the other levels, C5-6 and C6-7, show us a perfect position of the devices in the X-ray control. At the end, we do an AP view to see that the implants are good in the midline of the cervical spine.
Okay, Dr. Illerhaus, the surgery took 3.5 hours. How do you think it went?
Well, I think the surgery was good. We have no complication due to the fact that we have 2 surgeries in one. What means lumbar intervention and cervical intervention. The surgery time was okay. The blood loss was really less. There was a little bit more preparation time we need for the cervical spine due to the fact there was a surgery before and the scar tissue was really hard, so we need some time to handle that. But it was not a problem to restore the lordotic angulation and as well the height of the disc in the cervical spine as well as in the lumbar spine. And so I was confident that he will really improve from the surgery. So we will see what happens.
Thank you.
Had my surgery exactly a week ago today. I had 3 discs replaced in my neck and 1 in my lumbar. So C2, 3, 3, 4, 4, 5 and also L5S1. Surgery-wise, surgery sites, not a problem at all. It's actually quite comfortable. A few little muscle spasms, a few little aches and pains, but nothing compared to what I was living through. The staff were very good. It helped knowing a little bit of German, and if you don't know German, I would recommend to Google Translate. It helps a lot, even if it's just for the basics. But they were quite good. The surgeons were awesome. Information was always available and in English, and that made a real difference to knowing what was going on and what was going to happen. It was really, really good experience. Looking up ONZ, looking up Jake, spine connection, it was all new technology. It's all been approved here, and when you outweigh the costs compared to living in pain for years, waiting for surgery, for approvals, there's no question about it. This is all easy, one go, it's all done.
After 6 weeks of rest.
I want to jump on the trampoline with my kids. That's pretty much it, and climb a tree. I don't care if I fall out and break a bone, that's fine. I just want to work with my kids, become active again.
Be less grumpy.
Yeah, I'll have to throw my Mr. Grumpy t-shirt and mug out.
We were very scared that it was false promises. We've had a lot of false promises, and to have every promise completely met has just been, I can't put it into words. It's just wonderful.
It's a lot of money.
Yeah.
And when you're passing a lot of money overseas,
Had a meltdown in the bank on the bank transfer day. It was scary.
but it's little, when you finally get on the plane and finally make it here, and then you actually have someone to meet you at the end, that was just a relief. It was a real relief.
What we can see here, this is the angulation of the cervical spine, similar to the lumbar spine. It's good, and we see here the implants are good in place in the level. These are the artificial disc replacement, and this is the fusion, because there was too less distance, so it was not a good idea. You see the angulation here is too bad, so with a combination of a fusion and 3 implants, working implants, and from the front view as well, they are all good.
This is Jason Warmer at his final check, and Dr. Illerhaus is now examining him to make sure that the incisions are okay.
So the incision looks well. You don't need to drape anymore. That's fine. So, okay, good, perfect. Swollen, it's free. So maybe there's a little bit of irritation.
Yep.
But that's fine. Okay, or painful.
Not painful.
Okay. Not painful. Okay, but now go a little backwards. That's a little painful for you.
No.
Okay, lift it up. Perfect. And you can sit up. That was the final check.
If you would like for our spine specialists to evaluate your case, please visit www.spineconnection.org or click the link in the description below. A second opinion can make all the difference, and we are here to help.